Good afternoon, everybody, and thank you for joining us on this webinar, Irritable Infants. This webinar forms part of the Rural Health West 2020 virtual conference. Before I hand you over to your presenter, I would like to run through some brief housekeeping. If your audio is not coming through too clearly, you may prefer to switch to audio via your phone. These numbers will be listed on your dashboard. Remember to enter your PIN number too. Everybody has been placed on mute to minimize background noise, but we would still love to hear from you. Please enter any questions into the question box, which you should be able to see on your dashboard. The presenter may choose to answer these straight away or save them to the end of the session. This session is being recorded and uploaded to the Rural Health West website under the virtual conference banner. I'll now hand you over to your presenter, Dr. Jehangir.
Welcome all. It's Dr. Mohammad Jehangir. As Beth said, I'm one of the consultant pediatrician. My practice is based at St. John of God Hospital, Mount Lawley. 3 days a week I'm there for private clinic, and 2 days I'm at public hospitals in Perth, at the moment Armadale Hospital. And it's lovely to talk to you on Friday. Hopefully we'll have the good start to the weekend. So today
Dr.
we're going
Jehangir.
to, yeah.
Sorry, it's Beth here. I'll just jump in quickly if you don't mind. We can see
sure.
your PowerPoint slides beautifully, but if you don't mind just clicking on the icon which says from beginning, and then we'll just see your pictures. That's it. Perfect.
Okay.
Thank you.
Yeah, good. So today we'll talk about in next 40 minutes or so about our approach to irritable infant, very unsettled, crying infants, and common conditions which can be responsible for irritability, as well as how we manage those conditions. And I would love to answer your questions. So let's start. As you can see, very unsettled baby. This is one of my patients at St. John of God Hospital, Mount Lawley, some time ago. If you look at the picture, it looks very distended abdomen, very shiny, distended abdomen, and you can see the nasogastric tube. This baby was initially premature, about 34-weeker, born at the time of birth at 34 weeks, and then had some respiratory issues, respiratory distress, was ventilated, then came back to us, and he was about to be discharged on this day when we saw quite distended abdomen. Baby was opening bowel, but this was obviously a concern. He was vomiting and had quite a bit of distended abdomen, so which could be one of the problem with unsettled babies. But this baby, for our surprise, was hypothyroid, congenital hypothyroidism. And interestingly, his first blood test for thyroid test was normal. This is the same baby, looking a lot more frightening. So baby was transferred to Perth Children's Hospital, where all the surgical investigations, including biopsy for Hirschsprung disease, was done, and ultimately responded well to thyroxine therapy, thyroxine or thyroid hormone. This is another sort of problem with unsettled babies, which most of the time is not looked at. So we must always think about large heads or increased intracranial pressure if there is nothing obvious for irritable baby. This was another client of mine who come from a very good family, socially and caring wise, very, very a good family. And the baby in about 2 to 3 months time, from well-looking, well-nourished baby, has become like this, that you could see all the ribs and there was hardly any muscle mass left. Parents attributed this to bronchiolitis episode 3 months ago, and after that they thought baby has not been doing well. The most striking thing about this baby was to start with very distended, bloated abdomen. So I did celiac serology. TTG was 257. That's very high, very high. So that confirmed on endoscopy this baby had celiac disease. And after being on gluten-free diet, everything normalized. Sometime we do get these surprises, these sort of pictures. This was another about 6-month-old baby of mine whose father was looking after him, and initially he didn't come up with any history, just a swollen leg for no reason. But later on, he said he has twisted the leg because baby was crying and he couldn't make the baby quiet in a somewhere car racing event. So then he just twisted the leg and that happened. So I'll just move this a little bit. There's some problem with the, but I think there's some problem with the slideshow now.
There we go. We can see your slides, Dr. Jehangir.
Okay. Okay.
Yeah.
Yeah.
All good.
All good? Okay.
Yeah. If you just want to click on that from beginning, or
Okay.
and then just click through to the slide that you were sitting on.
Yeah.
There we go.
There we go. So this was just some of the ideas to give you what we need to think about. And now if we look at the differential diagnosis of irritable infant, these are some of the causes come to the mind. That reflux, obviously, gastroesophageal reflux, it's very common. Lactose intolerance, also very common with Aboriginal and Asian children or babies. Cow's milk protein intolerance or allergy. Intolerance is a lot common than allergy. Otitis media, raised intracranial pressure, and non-accidental injuries, as we mentioned. Constipation, generally a bit older kids, like a few months to few years. And urinary tract infection, most of the time are asymptomatic, but we do see children who are unsettled or UTI causing gastroenteritis, and that way making the child or baby unsettled. Colic, and sometime parents' perception, child may be having normal cry, but parents taking it disproportionately abnormal. So just to give you some idea, 6 weeks old infant who cries and vomits a lot. Mother is sick of washing his clothes. It takes about an hour for him to settle after feed. weight gain is still at 50th percentile, and this infant has no diarrhea. So this is very, very common presentation, especially with the child health nurses and the general practitioners. Most likely, this baby will have, as you guessed right, gastroesophageal reflux. What is gastroesophageal reflux and when it can be a problem? The gastroesophageal reflux is obviously a bit of positing, vomiting, and irritability after feeds, which can be positional or gets better by bringing the kid in upright position, and it settles after about 30 minutes or so. Most of the time it's normal. Most babies go through this phase, but sometime it can be a problem. And then it's called pathological. So if the reflux is happening quite often, more than 10% of the total time, the child is always having reflux or bringing the gastric contents up, then it can be a problem. And or if the child is having significant feeding difficulties or is associated with number of vomiting, so more than 5 times or so vomiting per day. So back arching was not increased in infants with gastroesophageal reflux, and in the absence of frequent vomiting or regurgitation or feeding difficulties, pathological gastroesophageal reflux is unlikely. The negative predictive value is up to about 90%. So if it's just a bit of spit or changing clothes and child is settled, happy, then that is either due to overfeeding or just a little bit of physiological spitting, but nothing to worry. Why does it happen in the babies? So there are some anatomical factors. One of them is angle of His, that's your angle of esophagus to the stomach. And in babies, it is a bit more straighter, as we will see in the next slide, while in adults, it is at an angle. So we do feel less reflux as adults, but babies under 3 to 6 months of age, they have a lot more common reflux because of the anatomy of their esophagus and the stomach. And that's what we were talking about, that this number 6 in this picture, that there should be some angle in the adults, and it's much more straighter with the babies. Food intolerance or allergies makes the reflux more prominent or more obvious, and this could be your lactose as well as cow's milk protein intolerance. And transient relaxation of the esophageal sphincter believed to be the main mechanism, that the sphincter at the lower end of the esophagus intermittently relaxes, and when it relaxes, the stomach contents come up, especially when the stomach is full or the baby is in a supine position. There about 94% of reflux episode in children and adults are thought to be due to this transient relaxation of the lower esophageal sphincter. So symptoms, again, it's the vomiting, number of vomiting, especially if it's 5 or more. And poor feeding, in absence of vomiting and feeding difficulties, it's very unlikely pathological reflux. How do we diagnose? The history is most important, as with many other medical conditions, that we take a good history that includes all perinatal history, delivery mechanism, and all that. Family history, what sort of family support mother or father is having, and the feeding habits of the baby, breastfeeding or bottle feeding, and how much volume are parents giving. Do they feed with the bottle every time the child cries? Child may be crying from a wet nappy or dirty nappy or cold, or just sometimes babies do cry. That's their normal way of communication. So, and every time baby cries, parents giving a bottle, that would obviously that would lead to vomiting or reflux. On examination of these babies, if it's typical physiological reflux, you will find nothing abnormal, nothing abnormal. The examination is basically to check if there is anything else going on, to exclude certain condition. And those, some of those we listed in the differential diagnosis, and like large head or pyloric stenosis or any other neurological or developmental disorder. So examination is targeted toward excluding other causes rather than diagnosing reflux. And investigation, obviously, we do for certain condition, but for common reflux, gastroesophageal reflux, which is a lot more common in general population, no investigation is required. You just reassure the parents, child is doing well, he's gaining weight, he's developing, and his vomitings are only small in amount or number. So no further investigation is required in more than 90% of cases. And while we taking history, these are the things that when the child is irritable in relation to the feeds and in relation to the position. Is it more irritable and vomiting in supine and soon after feeds, or is it any time? And how long does it take for the child to settle? If it takes about 30-40 minutes, then is more likely the reflux. Then there will be some warning signs that this is perhaps little more than just the physiological reflux. And if you find those warning signs, that should alert you to investigate further. These warning signs can be, as you are thinking, right, the color of the vomit and the content of the vomit. So if it's bilious vomiting or blood-stained vomiting, blood from upper and lower end of the bowel is significant. So if there is a forceful and big amount of vomit, onset of vomiting after 6 months of life, constipation, diarrhea, abdominal distension or tenderness, as we saw in the first slide, and if it's associated with the recurrent lower respiratory tract infection, so that is possibility the child is aspirating or having tracheoesophageal fistula. So these are some of the things which, when you're taking the history or you're examining the child, we should focus on. Some other signs which could lead to neurological problems are hepatosplenomegaly, large or bulging anterior fontanelle, big head or small head, any abnormal movements, hypotonia or hypertonia, can be both signs of the cerebral palsy or upper motor neuron lesion, and sometimes other abnormal features such as Down syndrome or any other syndromic features we find. So these babies will have low tone and swallowing difficulties and stuff, and more at risk of aspirations and chronic infections, if that could be the cause of poor weight gain and stuff. And then there are non-specific symptoms such as fever, suggestive of lower, if there is no other cause, lower respiratory tract infection or pneumonia. Lethargy, the child is not as active as it should be, so that should also point to some other causes than physiological reflux. Failure to thrive, I must say, or a common teaching is that failure to thrive is not part of the physiological or common reflux, gastroesophageal reflux. If you find failure to thrive with vomiting, we must try to look further. We must try to find a cause, something other than normal reflux. And on examination, like I said before, it's generally a well and thriving infant, except when having the episode. It might happen during your examination or during your consult that child suddenly goes very red and starts screaming. But sometime when the parents come, the child is settled, happy, so you don't believe what parents are saying. So that could be misleading. And exclude other causes. Like I said, urine test is helpful, head measurements and checking for increased raised intracranial pressure, and if there is any particular tender spot, raising the possibility of non-accidental injury. Most of the time, no investigations are required. Reassurance and some lifestyle changes. If mother is breastfeeding or bottle feeding, then we might have to adjust the volume and the number of feeds. Barium swallow is a relatively easy investigation, especially I believe most of the attendees are from the rural areas. So this is a useful investigation for people in Geraldton, Kalgoorlie, or Broome and Kimberley, that side. Any radiologist can do this. And if it does show reflux, that at least reassure the parents that that is the possibility of baby's irritability or unsettledness. Also, if it does show the aspiration, then it needs to further investigate that why child is aspirating. Is it fistula or is it incoordinated swallowing? pH monitoring, mostly not done, but we can do it in Perth with the help of one of our gastroenterologists. So how it is done is by putting a little catheter in the lower third. The lower end of the catheter is in lower third of esophagus, and outside it is attached to a little monitor. Every time a child cries, we ask the carer or mother to press the button on the monitor to measure the pH of the esophagus at that time. So if the pH is acidic at the time when the child is crying, so that correlates with the reflux episodes. Endoscopy, we reserve it for extremely uncommon clients who haven't settled with common therapy and it is ongoing or causing problems. And a little bit older kids who we expect to be improving, but they don't improve. So this would be to confirm reflux esophagitis, as well as to exclude or include eosinophilic esophagitis. And other investigation depends on what do we find on examination or history. Treatment for gastroesophageal reflux is most of the time reassurance that it's a common problem, it will go away with time, We just manage with the lifestyle changes, positioning, things like that. And if parents are smoking, they can stop smoking. Smaller and more frequent feeds, usually 3-hourly feeds instead of 4-hourly feeds. Keeping the child upright for about 15 minutes or so after feed. And milk thickeners, over the counters are available. Milk thickener like Aptamil milk thickener, or any other one, whatever is available. And if the mom is breastfeeding, 2 weeks trial for a dairy free diet. That mother doesn't take any dairy, and that includes milk, cheese, yogurt, ice cream, chocolates. Only yesterday I had a mother who said, "No, I don't take any dairy." And I said, "What about cheese?" She said, "Oh, I love cheese." So things like that should be all included in dairy. And then if that doesn't help, then 2 weeks trial of modified cow's milk formulas, and these can be extensively hydrolyzed milk formulas to start with. In Australian market, no preference to any particular one, but available formulas are Pepti Junior and Alfare, ALFARE, and Pepti Junior. Then if we have to go further, amino acid formulas are also available if the child doesn't settle, and proton pump inhibitors, Losec, is the commonest medication at the moment used by gastroenterologists and pediatricians and by our lovely GP colleagues. So the trial of proton pump inhibitors should be only few weeks, and if after 8 weeks there is no change, it can be stopped. This is very busy slide, but basically it takes us through those steps. You can enlarge it later on and have a look, but basically it takes us through the same approach that is it a physiological reflux or there are any warning signs. If there are any warning signs like bilious vomiting or failure to thrive or blood, you investigate it further. If there are no warning sign and the irritability is uh, quite stressful for the baby or the mother, then we go through those steps as I mentioned. um, Cow's milk products eliminations from the mother's diet, and then thickener, and then proton pump inhibitors. So that's basically all in the same slide. And this is from up to date, as you can see. Uncomplicated reflux, but it's causing a serious stress to the family. There you can try some of those things I mentioned, but otherwise continue with breastfeeding and support, social support like grandparents or extended family members to look after the baby for a few hours in between breastfeeding. It's fine, and keeping the baby supine after feed, and also putting a little wedge or blanket in the baby cot at sleeping time. So about 30-degree head side elevation is helpful. Okay. What if baby is having poor weight gain and vomiting? This is quite a significant issue, and we should not take it that easy, because it happens quite often that if the child is not gaining weight, most of the time, I'll give you few examples, but most of the time it's pyloric stenosis. I have seen cases when the child is not gaining weight, pyloric stenosis, UTIs, and congenital cardiac uh, lesions like VSDs or truncus arteriosus, basically heart failure from congenital cardiac problems, large VSDs, or any significant left to right shunt causing the heart failure. So pyloric stenosis is much more common of these conditions, and we regularly see. One I saw only a few weeks ago with vomiting, and he was still very early, only 3 weeks old, and he's just starting to lose weight. Even first ultrasound was borderline, and his blood gas was also borderline, but he did look typical, like a little bit wasted, and he's a first child, first boy in the family. That these are the babies who are more likely to have pyloric stenosis. So I sent him to Perth Children's Hospital, where they observed for one night, and next day they operated and they found hypertrophic pylorus. So blood gas, I am sure in most of the regional hospitals can be done and is very, very useful. If you do capillary or venous blood gas, normal pH should be about 7.35 to 7.4 or just above that. But if it's 7.45 or above, that is very suggestive of pyloric stenosis in children who are vomiting and not gaining weight. Ultrasound is another thing you can request, but again, that depends on the sonographer's ability to take the picture and radiologist experience. Some of the regional radiology departments may not be that comfortable, but with the history of vomiting, the age around 5-6 weeks, and the blood gas alkalotic, so high pH 7.45 and above, and high bicarb, usually above 25. And if you can same time look at the potassium, that is very helpful, because these baby will have low potassium and they will run into trouble from cardiac arrhythmias rather than dehydration or weight loss. So they need to have a potassium replacement if it's very low before they go for surgery. So this is very, very useful investigation, capillary or venous blood gas in the rural settings. I'm not sure how many facilities have that handheld um, gas machine, the RFDSUs. When I was in Geraldton and Kalgoorlie, we did buy for those hospitals. It's called iStat. So just a very simple handheld machine which can do the blood gas as well. So food protein, proctocolitis, if there is fecal blood, I mean there is any blood or fecal occult blood in the pus, and food protein induced enterocolitis. And fecal calprotectin we can do for investigation. This indicates the inflammatory condition of the bowel. So if there is enterocolitis or other conditions which will be very uncommon in younger babies, such as Crohn's disease and ulcerative colitis. Full blood count to see if the baby is anemic, and stool MCNS, urine MCNS to see if there's any infection going on. Similarly, CRP, ESR, and colonoscopy if we suspect anything else going on. Upper GIT scope, as I mentioned before, for esophagitis and eosinophilic esophagitis. Prognosis generally is excellent. Most cases are benign, and 80% will resolve before 10 months or so. Most of the time, like we mentioned before, lifestyle modifications and medications as required. The problem with medication you all may have faced is that Losec or Zoton, Z-O-T-O-N, is available as tablet form only or capsule form. So dissolving the tablet in water or breast milk is possible, but is not easy job for the parents. And Losec, even if you dissolve still have a small pellets, which can be difficult to give with the syringe. The compounding pharmacists can make liquid form, but that shelf life, though they make it for a month, but after 2 weeks, you don't see as good effect as it was freshly made. So that is the main problem with the proton pump inhibitors. Surgery is very rarely required. I can't remember any of my patient in recent years requiring surgery for gastroesophageal reflux. But yes, if it's not settling after 12 months of age, that is something to be considered. Or most of the time, surgery is required for these syndromic kids, cerebral palsy sort of kids where the muscle tone overall is quite low and the child continue to vomit. So then in that case, they can surgeons can do the pig instead of feeding through the mouth. So we feed through the peg. So this is another unsettled baby, which we will probably discuss another condition for this one. This baby cries anytime, but mostly in the evening, 3 times of the week and for 3 weeks. He doesn't vomit, his stools are soft, weight gain is okay, he doesn't have any skin rash or wheezing. So as you guessed right, these sort of babies will have infantile colic, which is again quite common, but this is diagnosis of exclusion. And for colic, there is a rule of 3 that generally starts after 3 weeks and crying after for about 3 hours and more than 3 times per week. No vomiting or diarrhea, no other symptom. Examination is essentially normal and weight gain is appropriate. So in this condition, again, no investigation is helpful and no particular treatment is effective. A lot of pharmacies in Perth use pharmacist own mixture or colic mixture, they call it, but basically Infacol was widely available before. Now there is some problem with the supply, but what these mixture or Infacol has is simethicone. Simethicone is a little chemical which just breaks the bubble. It does not get absorbed into the system, does not have any side effects other than that it just breaks the bubble. So if there is a bit of wind, that helps for it. Otherwise, it has no other function. And this slide should suggest that the stress on both babies and mothers can be vicious circle. So if parents are anxious, the child can be anxious, and then if the child is crying, that could cause maternal stress, lack of sleep, and then anxiety, depression, postnatal depression, and that makes child further anxious as well. So that needs to be the maternal condition or mental health being should be looked at. I had one of my colleague in one of the peripheral hospital who had twins, and one night around 9 p.m. he was so stressed. He asked me, Mohammed, you must take away these twins. We cannot handle them anymore. Oh my God. I said, oh. And the mom was a nurse. The father was our colleague at hospital. So we had no option other than admitting them for a few days. Parents can have some rest. Ultimately, these babies had cow's milk protein intolerance, which settled with appropriate treatment. So it can be very stressful for the families. This baby It's one of the Aboriginal girl I saw at 4 months of age. The baby looked merasmus or merasmic. I'm not sure if people are familiar with the term merasmus, but I did see quite a bit of this problem in Johannesburg, South Africa, where the kids or infants were very malnourished. So if you have total malnutrition, then there will be no muscle bulk, no subcutaneous tissue, and these kids will be looking basically skin and the bones. That's how this baby, Aboriginal child, looked when we saw her. Parents reported that she's only unwell for about 2 days with vomiting and diarrhea, and the stools were quite windy and frothy, and she also had nappy rash. So I thought of, because of her Aboriginal background, as well as that she was quite underweight for her age, so we decided to admit her to see what's going on and do some basic investigation, including stool and urine MCNS. She did have a little bit of poor suck, and that could just be because of her malnutrition. Some of the milestones like head control was also not very good, and mother had a pacemaker for herself, so she also had a health issue. So we thought she may have some social issues, maternal health issues, and then if the child is not gaining weight, so it's good to get all these things sorted out as inpatients. So we involved all child development team members that include dietitian, social worker, and speech therapist. This baby at first admission, as you can see, the sodium was 137, potassium 3.4, so a little bit low. Bicarb 18 again, low, urea 2.8, not high, and creatinine 36 also not high. The urea in this case may not be high because child have no much muscle bulk. So urea, as you know, comes from protein metabolism, nitrogen breakdown. So this child may not have much protein in the body, so urea could be low in such cases. So it's a falsely low for dehydration. But if we look at the bicarb and potassium, so it does look like the child is a bit dry. CRP was less than 3, so mean no major bacterial infection going on. We started the baby on lactose-free milk, considering that she's Aboriginal. She has classical symptoms of frothy, loose, frequent stools, and nappy rash. So after a few days, baby started improving, so we discharged her. And then she presented again in worse than the first presentation, worse condition. She was now dehydration was worse. We were unable to get any peripheral intravenous line. Then we got external jugular line in the neck, and you can see her electrolytes deteriorated. Sodium is 125, potassium is 2.6, bicarb is 13, so she is in quite a severe metabolic acidosis. CRP on the blood test still remains less than 3. So at this stage, she needed intravascular potassium supplements or intravenous. So we had to transfer her to PMH or Children's Hospital, that time PMH. There she was stabilized, and mother couldn't stay too many days in Perth, so she discharged herself against medical advice, but presented to Peripheral Hospital in Geraldton 5 days later. And diarrhea continues to be problem. Again, she's very acidotic, peripherally again shut down, and after about an hour or so, we were unable to get any peripheral line, so we had to put intraosseous drip for her. So this time her bicarb is 10, sorry, bicarb is 0 and urea is 10. Now the urea is gone up and creatinine is gone up to 81. So that means she is in going acute renal failure. CRP is still less than 3, so it's basically all dehydration, metabolic acidosis and dehydration. So she was again transferred to Princess Margaret Hospital, where she had a very long hospital admission for more than a month. And at some stage, she required dopamine infusion to keep her blood pressure up and circulation. The good news was that after all that, she recovered well and she went to school at about 6 years of age. I could not recognize her that she is the same girl. She was looking very well nourished and well developed for her age. This is another Caucasian baby who we diagnosed initially with tracheoesophageal fistula. So post surgery repair was done successfully, but the child was remaining irritable, and it was in fact getting worse. The irritability was getting worse, and he did have history of loose stools. The child was put on Losec or omeprazole. That didn't help. That was considered uh, for reflux, gastroesophageal reflux, but that was not helping. When we did the stool test for this baby, that came positive for reducing substance or for lactose. It was 1%, more than 0.5% we take as positive. So that suggested that though child had upper GIT problem, but he has lower GIT problem as well. So he's not absorbing lactose. So we treated him with the lactose-free milk, and that helped to sort out some of his symptoms. Now, lactose intolerance, another common cause of irritability. It's common, lot more common in indigenous and Asian children. So what is lactose intolerance? It is basically when the babies cannot digest or metabolize disaccharides called lactose. Lactose, as you know, is a sugar in the milk, breast milk, and cow's milk. So if the baby is having some problem to digest the lactose, that leads to symptoms of lactose intolerance. And when it's properly digested, it is converted into glucose and galactose. These are monosaccharides, so sugars, monosaccharide sugars, and these are much easier to digest or absorb. The lactase enzyme is produced by the small intestine. So the digestion or metabolism of lactose starts in small intestine, but if there is total absence or deficiency of lactase enzyme, that leads to malabsorption of lactose. So that means the lactose will not be broken down and it will pass from small intestine to the large intestine as it is. And that's where the problem will start. It is a sugar where it will be broken down by some bacteria, and then it will lead to gas and acid production. And that will cause all those frothy, windy, frequent stools, and acid will cause nappy rash. How common it is? This is from Adelaide-based study group, or one of the study, that in Australian Caucasian population is not that big problem, but Aboriginals up to 84%, and Asians in Australia also quite high, and Greeks and Mediterraneans not so bad. 19 to 61 years of Caucasian people, again less than 20%. Aboriginals continues to be problem to some extent, but doesn't produce as severe symptoms as in the babies. Physiology of lactose intolerance, as I mentioned before. So the problem is mainly the lactase enzyme, whether it is relative deficiency or total deficiency. And as a result of that, there is a problem with the lactose digestion and absorption. Its severity depends whether there is total absence, and total absence luckily is very uncommon. It is a rare autosomal recessive condition. So as a result of that genetic pattern, it's not common, but partial deficiency happens in neonates as well as after episode of acute gastroenteritis. So primary deficiency again can be from birth, or it can be transient in neonatal period, or 4 or 5 days after, if the gastroenteritis of rotavirus or any other infective cause continues for a few days, and it can lead to temporary lactose intolerance, which most of the time is self-resolving, but sometimes we do have to treat it. Symptoms of lactose intolerance: vomiting, skin rash, abdominal distension, frothy stools, perianal excoriation or nappy rash, dehydration, and this might be some surprise to you, nephrolithiasis or renal stones, very small size renal stones, especially with our population and the regional people, Aboriginal people living remotely, quite easily dehydrated, Kimberley region where they're quite humid and hot. Lactic acidosis, constipation is not a symptom of lactose intolerance. I just put it up there to see when we have face-to-face presentation, I ask people which one is not a symptom. So that is not a symptom of lactose intolerance. Failure to thrive and anemia. Diagnosis of lactose intolerance basically is clinical, and also trying or challenging with feeding with lactose-free milk or giving lactase supplement. Stool test can be helpful if pathology can do it, if you ask for reducing substance in the stool, and it have to be the loose watery part of the stool that needs to be tested. Breath test is reserved for adults, and blood test again we don't do for children. Basically, you do glucose tolerance test. Similarly, you could do the blood test as well, but we don't do so. Only test which can be done for the babies is a stool test or clinical challenge, either eliminating the lactose from the diet, such as if you're breastfeeding, so stop breastfeeding for few days and see what happens, or supplement with lactase enzyme or stool test. So those are the usual things we can do for babies. What happens if you have excess acid, like we mentioned in the pathophysiology, like if you have significant lactose intolerance, it will lead to lactic acidosis, mean you will have a quite high level of acid in your body, and that needs to be excreted. As you know from your physiology knowledge, there are two main buffer systems in the body, the lungs and the kidneys. The lungs in this case are not a significant tool to normalize your acid, but babies will have a bit of fast breathing, so they can bring out or breathe out more carbon dioxide, and that way they can get rid of some acid from their body. But kidneys are the strong buffer. They're the one who will work quite hard to normalize your acid from the body. So long-term complications of lactose intolerance, we are talking now this especially with our regional babies, which we used to see a lot when I was in Kalgoorlie and some in Geraldton. Renal stone. One of our very senior pediatrician, Janine Spencer, she did many years ago some studies in Kimberley with Aboriginal babies. They did renal ultrasound, and I used to do also in Kalgoorlie. So babies who had significant lactic or metabolic acidosis as a result of diarrhea. We did their renal ultrasounds, and that confirmed microstones about 3 millimeter or so. Failure to thrive, end stage renal failure as a result of renal failure because of the dehydration, and delayed development caused by neuronal functional impairment from acidosis. Treatment, what can be done for babies with lactose intolerance? For breastfed infants, the elimination of dairy products does not help, because breast milk will have lactose regardless what mom's eating or drinking. So that is not an option, but we encourage those who are breastfeeding, we encourage the mothers to continue breastfeeding. So in these cases, enzyme supplement is helpful. Enzyme is available in the form of drops as well as tablets over the counter. Lactase, Lacteze. Lactase tablets are more effective than the drops. The drops are supposed to be put in a milk few hours before consumption. So if you want to use some milk tonight, you can put the drops now, and that will reduce the lactose content of that milk. But for the babies, the best they recommend is uh, lactase tablet, about half a tablet dissolved in a water or milk given before feeds. For bottle-fed babies, it's very easy because you just choose lactose-free formula. And most of the companies supplying milk in Australia, they do make lactose-free brand as well. So Caricare, S26, Nan, Aptamil, all of them have lactose-free milk available. Duration of treatment, if it is temporary, as we mentioned, that someone having a week of diarrhea from a enterovirus or other infective causes, and now we think it is a secondary lactose intolerance, so you could try reducing the lactose content of the baby's diet or giving lactose free milk if the baby is only drinking milk. So that is only for few weeks, 4 to 6 weeks, and that should help to regenerate all those villi in the small intestine where the lactase enzyme is produced. And then the baby should be fine. With most of the Aboriginal babies, we find the problem continues for about 12 months or so. So there we treat it for a little longer period. And for those patients who have re-emergence of symptoms, if you challenge after a few weeks, you've given lactose-free milk, and then we tried normal milk, and they have symptoms again, those babies qualify for PBS subsidized lactose-free milk. So that little financial help for the struggling families in the regional areas. Lifelong, only if the symptoms are bad enough that causing tummy pain and stuff. I had one of my medical student whose partner could not eat pizzas and stuff or lactose containing food. So once we gave him a Lactase tablet and he was smiling next day. So like that, if there is any planned uh, meal you want to eat, that there it can be helpful for patients who have lifelong symptoms. But for those people, elimination is the best treatment. Treatment options for non-responders, those who do not typically respond to lactose-free milk. There are other options. Soya-based milk is good for children who are 6 months or older, but below that age, we have special PBS subsidized formulas, and those are basically cow's milk protein modified and lactose free formulas. We are thinking if the child is not responding to lactose free milk, that there may be problem of cow's milk protein absorption as well. So there are special formulas which I will go through with you in next slides. Carbohydrate free milk, so that means this milk has no carbohydrate at all. This is used in extreme cases, and it was used with our that 4-month-old Aboriginal girl uh, I mentioned earlier on. It doesn't taste very well, so it have to be given by nasogastric tube. And intravenous therapy for a few days, or total parental nutrition. And this option was also exercised with our Aboriginal girl for a few weeks at Children's Hospital. Uh, Carbohydrate-free milk, like I said, you have to be given with the tube. And this has a very special protocol of administration. We don't need to go through this because mostly it will be done at hospital. So they start with very low calories and gradually build the calories and the sugar content. And then after a week or so, they go to the lactose free. And if symptoms develop with the higher sugar content, then you go backward. And if it fails, then you think about other malabsorptions or infections. Sometime with older infants, there are hidden sources of lactose, such as the bread or baked goods, processed cereals, instant soups and drinks, margarine, salad dressings, candies, so things like that, biscuits, cookies. You need to have a very good dietitian if the symptoms are ongoing. So pediatric dietitian's involvement is important. This slide just shows the lactose content and the calcium in different food items, ice cream, yogurt, milk. So again, for dietitian to look at if the lactose content is more than 10 gram per 100 ml of a drink, that is considered moderate or high. Some of the low fat milk will have a high lactose. We have to be very careful with those. Sweetened and condensed milk will have high lactose or carbohydrate content. Chocolate milks, goat, yogurt, and sour cream and stuff. If it's less than 10 gram per 100 gram or 100 ml, that is considered relatively better or safe. So ice cream, human milk, skim milk, like those things. Renal stones, as I mentioned, is one of the complication of lactose intolerance or metabolic acidosis as a result of lactose intolerance. And these sort of stones are seen in these children: urate, ammonia, uric acid, and calcium oxalate stones. And why these stones are formed, or pathophysiology of these stones, is that when there is a severe acidosis that leads to high content of lactic acid in the body, and when the kidneys are excreting or getting rid of that acid, so that have to be done in the form of ammonia to take more hydrogen ion from the body, and that leads to renal stones. So renal ultrasound, especially like those areas I mentioned, our peripheral Warburton and Kimberley and Port Hedland, Kalgoorlie. So there it is useful investigation, and giving a bit of bicarb or alkali and rehydration helps to get rid of those stones. Now, this is the summary or very, very useful slide understanding the milks. It is very confusing when there are hundreds of milk brands available in the market. So this should be your take-home message for the milk. We divide the milk in basically two categories: humanized milk, which is breast milk, or close to the breast milk, or close to humanized milks are all your standard formulas, which include no preference to anyone, NAN, S26, Care, whatever, Aptamil, Lactogen. And then there are special milk formulas such as lactose-free milk, which is reduced, or formulas for cow's milk protein intolerance or allergy. And these are your extensively hydrolyzed milks such as Pepti Junior and Alfare, anti-reflux milk for reflux babies. Soya milk we only use for 6-month and older kids. Goat milk we do not recommend, but a lot of families will ask you. The dietitian and College of Pediatrician do not recommend goat milk. There is a relatively newer formula available now in the market, and that has been suggested by Children's Hospital gastroenterologists. That is Novolac allergy. That is rice-based formula, Novolac allergy formula, if we think there is a cow's milk protein intolerance. So for cow's milk protein allergy or intolerance, partially hydrolyzed milk formula, which previously was NAN HA or NAN Supreme, mostly not helpful after you have symptoms, but it has a role in prevention. Extensively hydrolyzed if you have developed symptoms, but this one needs to be initiated by pediatrician, and then GPs can continue prescribing. Amino acid formulas, there are 3 at the moment available in the market, and these are reserved for either allergy or anaphylaxis, or for babies who do not respond to extensively hydrolyzed formulas. And Neocate, Alicare, and Alphamino. These are 3 commonly used or available formulas in Australia. And this recommendation is, the milk recommendation is based on American Academy as well as the European League. So breast milk is the best. In case of cow's milk protein intolerance or allergy, so extensively hydrolyzed formulas are the first choice, then amino acid formulas. Soya is not recommended under 6 months. And the support comes from these organizations, European Society of Pediatrics, and probiotics, not yet widely recommended, but there are some studies uh, suggesting that it could be helpful for some babies when we have tried using all formulas and no success. I suppose there's no harm in trying probiotics. Quite expensive, small bottle, but something to consider. And that is the end. Any questions? I couldn't see in the question box. Beth?
Thank you, Dr. Jehangir. We have had a few people online this afternoon listening into the webinar. I can't see any questions that have come through, so I too think that you have covered the topic quite thoroughly, so we thank you. We are just a little bit over the hour now, so unless anybody wants to put through a question quickly, but thank you to everybody who has joined us for the webinar this afternoon. We hope that you have enjoyed the session. I would like to say thank you to Dr. Jehangir for his time with this recording and for being part of the Rural Health West virtual conference. Just as a reminder, we will be uploading a copy of this recording to the Rural Health West website. It will all fall under the banner of our virtual health conference, and we'll let all participants know when those recordings are being uploaded. So just a couple of thank yous from the participants coming through, Dr. Jehangir. So I think,
glad.
yeah, I think
Glad
we
did it first time. This is
yeah,
first time for
no,
me, and we did it well. And
yeah,
for participants, locating myself is quite easy. You can search my name, pediatrician in Perth, or Smart Peds, all one word. And I do help all because I worked in Kalgoorlie and region, Geraldton and Mikathara visiting. So I do help a lot of GPs with Skype consults. So if the patient come to your GP's rooms and we do Skype consult from there, and I can talk to the parents. GP can examine the patient for me. Like I say, most of these babies will have not much on examination. It's just talking to the parents and getting appropriate history. So I'm very happy to help you out via Skype appointments also.
great. All right, thank you, everybody. I will now close the webinar, and once again, thank you, everybody, for your time.
Thank you, Beth. Until next time. Great.
Thank you.